is sudden onset of psychiatric symptoms. There is associated history of confusion, visual hallucinations, or disorientation to time, person, and place. And the symptoms, if they do not correspond to any specific psychiatric diagnosis, or the medicine residents, if there are abnormal vital signs, and if there is history of coexistence of specific organic illness or sudden fluctuation of psychiatric symptoms. So they all point that this patient is more likely to have an underlying organic cause of his symptoms rather than a primary psychiatric illness. Next. So how will you differentiate between primary and secondary psychosis? Major Ajit.
So to differentiate initially, the onset and progression. First, in the psychiatric conditions, the onset would be more gradual. Onset would be insidious onset with gradual progression, while the others, there will be more acute onset will be there. Next would be the temporal associations. In, for example, if it's linked with another secondary causes, there will be a temporal association with the emergence of those causes, while in primary causes, there will not be any association. Third would be in primary psychiatric causes, the symptoms would fit into one of the psychiatric diagnoses, while others in secondary causes, it would be vague psychiatric symptoms that are not fitting into specific psychiatric conditions. Response to treatment is next. For antipsychotics, for primary psychiatric disorders, it will respond immediately or easily, while other causes in secondary causes, the response to antipsychotics will not be as good as the primary.
So again, it is important to differentiate between primary and secondary psychosis. Again, it goes, the approach is generally, the history, the age of onset, the type of onset. One important pointer is hallucinations. So more frequent in primary psychosis, and they are more likely to be auditory, and they are likely to be imperative with loss of insight. However, in secondary psychosis or psychosis which are secondary to underlying neurological conditions, they are more likely to be visual, and you are more likely to find an abnormal examination if you are expecting a secondary psychosis. The clinical examination also be pulse, whether it is tachycardia, tachypnea, are these symptoms fitting into a particular syndrome. So all these pointers, they help you to differentiate whether it is primary psychosis or a secondary psychosis. Right? Now, another person next to me. Yeah, please. So this patient was labeled as PIDS outside, and she was referred to a psychiatrist. Then how would you differentiate between PIDS and generalized?
Sir, depends on duration, sir. Duration, sir. And any prodromes, post-ictal confusion. The PN is psychogenic non-epileptiform seizure is basically a conversion disorder of an underlying psychiatric illness, sir. And what happens basically is like patient will have excessive movements. It is asymmetric, and the patient will also have waxing and waning course of a seizure, sir. Unlike GTCS, which will have either a progressive course or it is a static.
So many times you find reference, you will not even think that the patient, or you will find the reference from a psychiatric that this patient is having abnormal movements. So again, remember that the differentiation between PNES and GTCS is again purely clinical. So what is the history, what you find in the clinical examination, and what you find in the investigation. So investigations don't play much a part in it because most of the episodes don't happen in front. So again, they are supposed to be, in the younger individuals, GTCS can occur in all the ages. There is said to be some female preponderance for the PNES. Then PNES would occur mostly when the patient is awake, while the seizures, they can occur both during the wakefulness and sleep. Then generally there is a trigger factor for the PNES events to occur. It could be a psychological trauma or stressful situations, or maybe underlying sexual abuse. The duration, PNAS generally lasts more than 5 minutes. The seizures will not last more than 2 to 3 minutes. And then the position of the eyes. Most of the times in PNAS, you find that the patient is close the eyes and there is an eyelid flutter. Try to open the eyes, you won't be able to open them. Most of the times in seizures, the eyes will be open, though there are some certain kinds of seizures in which you can find ocular flutter also. Then the motor activity is generally out of phase. So there will be very large amplitude movements such as pelvic thrusting. They will not be stereotypical. In seizures, they will always be stereotypical. The kind if the person is having one phenotype of seizure, normally all the subsequent episodes will be like that one. And then the urinary incontinence is rare in PNES, though there are some people who can, can mimic even urinary incontinence. It is more common in GTCS. When you examine the patient, the presence of dilated pupils and a plantar or Golinski, which is upgoing, it favors generalized tonic seizures. You always remember that the incidence or prevalence of PNS is more in people who suffer from epilepsy or recurrent seizures. So it is not that a person who is having PNS cannot have seizures. Some of the episodes might be PNS, some of the episodes might be GTCS. Next. So one more differential is, just have a look at this video. So you can see that in this, it is some amount of the eyes, they are partially open and there are the movements are very large amplitude and they don't look like a serial-like movements. However, there are some violent motor epilepsies such as frontal lobe epilepsies. They can also have out of phase or very large amplitude movements. So in case, always keep on retaking the history. Please don't label anybody as PNAS in the first episode. Always keep on taking the history again and asking for a video of the event. It can save, it can help solve you lots of cases. Almost 99% of cases you will solve the cases. Next. So what are non-motor manifestations of seizures? Sorry. So seizures can present with number of non-motor manifestations depending on from where they arise. So they can have hallucinations, they can have delusions, they can have panic or fear disorders, aggressive behavior. Sometimes they might present as episodic impulsive behaviors. There might be fits of rage or agitation, or there might be severe anxiety. So they all represent from which part of the cortex they are arising. So next. So anybody can. Robin, what are the medical conditions which can present primarily with psychiatric symptoms?
Sir, metabolic disorders like in younger adults, Wilson, sir. Then, sir, even conditions like encephalopathy because of uremic or hepatic encephalopathy, sir. Then, sir, infections, sir. SLEs, autoimmune disorders like SLE, sir. And, sir, dementia, sir, in old age, sir, certain dementia like frontal temporal dementia, sir, Pills disease.
So almost any system can present primarily with psychiatric symptoms. Most commonly, also, of course, the neurological diseases. It can be encephalitis, epilepsy, demyelination, neurodegeneration disorders, autoimmune disorders, stroke, then hyperparathyroidism, hypercortisolism, hypothyroidism, then Wilson's disease, Bruegel's disease, hepatic encephalopathy, uremia, and please remember that substance abuse or substance withdrawal, that is a very important cause of abnormal behavior or primarily psychiatric symptoms presenting to emergencies of the hospitals. It could be an alcohol withdrawal, it could be cocaine withdrawal, marijuana, datura poisoning, drugs, anticholinergics, and always remember the infections such as enteric fever, neurocystic cirrhosis, toxoplasmosis. They can all present only with primarily psychiatric symptoms.
On investigation, her CBC was normal, liver function test and renal function test was normal. Her serum HIV, HBs, AG and NTHCV were non-reactive. Serum VDRL was non-reactive. Her USG abdomen was normal and MRI pelvis was normal. The thyroid function test and NT-TPO was also in normal range. CSF studies revealed that it was a clear appearance with proteins of 33 milligram per deciliter, glucose of 69 against the RBS of 112. The gram stain Zn stain in India was negative. There was no growth in culture, and PCR for MTB was negative. There were 10 WBCs, which all were lymphocytes. The CSF for
So what is your interpretation of this?
Sir, in this patient, protein is within the normal range, and the glucose is also normal, and the WBCs are more than 5. So this patient could have a picture of maybe a aseptic meningitis, or it could be a normal CSF with some inflammatory.
So can it be a viral encephalitis?
Yes, sir, with normal glucose and proteins.
She's not an encephalitic syndrome, so it could be a viral encephalitis. And
And it could be just inflammatory or some autoimmune.
the first years. Prakhar, person sitting beside you. Yeah, please stand. What are the indications of lumbar puncture?
Sir, fever with neck rigidity.
Please speak in the mic.
So fever with neck rigidity after we rule out raised ICP.
Okay, you've done that. How will you decide that you want to do a lumbar puncture in this patient? What are indications? You will not do lumbar puncture in all the patients presenting to emergency.
Local rigidity. It found from an
So, lumbar puncture can be done for diagnostic purposes or for therapeutic purposes. Diagnostic is when you want to plot an infectious etiology, or you want to plot an inflammatory, or you want to diagnose normal pressure and hydrocephalus, or you want to differentiate between the not able to find anything on the CT, but it's a disease product, protein supplementary. And even for diagnosis of you have to do a diagnostic lumbar puncture. Then therapeutic aid for IAS or for factory based tests. You can do repeated lumbar puncture and for the administration of intrathecal, which is intrathecal for decent and good lymphoid treatment. And of course, you have to treat the things for in case of typical pain the post-operation. Next. So, anybody who can describe what this is in this case? Across all specialties. Secretary?
Sir, there are focal epileptiform discharges which are lateralized only in the frontal left-sided leads, sir.